Continuing with the 2021 pathology paper, we had ended, we answered question 1, we did question 2, we also did question 3. So we are starting from question 4 with the paper. A 60-year-old man presented with shortness of breath, which had developed gradually, just the word, I love the word gradually there, over several years. A heavy smoker since the age of 20 is 60. On examination, he was short of breath. Nice one. At rest. And central cyanosis. He had a barrel-shaped chest, important also, and a marked expiratory wheeze. There is also a wheeze there. And then we've been told that on X-ray, CXR showed hyperinflation and other signs consistent with emphysema. At it, gas, you can see the pH is low. Partial pressure of oxygen is also low. That's 8. The normal is 11 to 13. Partial pressure of carbon dioxide, we can see is high. And then single breath, the SBC, single breath count is 36. Normal 22 to 26. So that's high. Which type of emphysema is associated with smoking? Anyone that can help us with that one? Which type of emphysema is associated with smoking? We have got what we call restrictive lung diseases and obstructive lung diseases. Obstruction just means that the airway is small. That's the meaning. And for the obstructive lung diseases, we have got asthma, which we already talked about, and also what we call chronic obstructive lung diseases, and we have got two there. We have got emphysema and chronic bronchitis. Now, when you look at, let's just mention something about the two. If we start with the first guy with chronic bronchitis, because the two makes up what we are calling the COPD, chronic obstructive lung pulmonary disease or lung disease. So in chronic bronchitis, what happens is that the patient is smoking, is a smoker. And because of that, the smoke or the cigarette contains some chemical things like tar, nicotine. So those things are going to be able to attract inflammatory cells, and that is going to lead to inflammation in the respiratory system. And so what you are going to be able to see in chronic bronchitis, that is, there's going to be a lot of mucus production because of the inflammatory response to the smoking. And then there's also going to be fibrosis. So the smooth muscles, the tissue will be dying, and so that leads to the fibrosis. Actually, you need to take note that bronchitis itself affects the larger airways. You have got the trachea, you have got the bronchus, the primary, and then the secondary. So chronic bronchitis affects the larger airways, while emphysema affects the small airways, like at the end where there is gaseous exchange. So besides the fibrosis and a lot of mucus, you are also going to have bronchospasm. So this is basically the contraction of the airway. So the airway has ended up becoming very small, very small. And so what happens because the airway is small? There is going to be difficulty in removing air and same difficulty with taking in air, but more difficult with removing air. So if you look at the end, at the alveolar end, because it is difficult to remove air from the alveolar, these guys, like they have got hair piling up inside them, and so they are hyperinflated. So that is one thing. And because of the hyperinflation, what you are going to be able to see is difficult in breathing, because there is no space for you to take in more air because you are failing to remove air from them. So specifically in chronic bronchitis, what you are going to see is a productive cough. You are also going to see dyspnea, the difficulty in breathing. You also see wheezing. So, so because the airway is blocked. So smoking is by far the biggest factor that is going to cause this. And then for how are you going to differentiate from emphysema, which is also COPD? When you look at emphysema, the causes for this condition, number one, you have got the reduction in the elasticity of the smooth muscles that surround the alveoli. Remember, we said that emphysema affects the small airways, like at the end. So there is going to be reduction in bronchoelastic tissue or reduction in elasticity. Besides that, you also have the destruction of the septa of the alveolar. So you have got what we call alveolar septal destruction. So this is important to know, because what you are going to see is this: you have got one alveolar like this, and then you have got another alveolar. You have got another one. So what you are going to be able to see is you've destroyed the septa, and you are going to see these guys ending up connecting. You're supposed to have this as one alveolar, this as another alveolar, but you can see the septa on the middle is destroyed, and so you end up forming one big alveolar. Okay. And this is one characteristic feature that differentiates chronic bronchitis from emphysema. You have got big sacs of alveolar. And then another thing that you are going to have, of course, is also fibrosis. So you can see in chronic bronchitis, there is bronchospasm, there is also increased mucus, but here those are not there. And by the same thing, smoking is going to be the cause. But can you see that there is elastic tissue decrease? What is the cause of that? In smooth muscles, we have got elastin. Now, that elastin is being degraded. So, here is our elastin. And we have got this scissors, which is what we call elastase. So elastase is breaking down elastin. And so because there is no elastin, what does that cause? Think of a bag, like a plastic bag. A plastic bag, you can pull it. It can become big, but it will not come back. That's what happens if you don't have elastic tissue. You are going to pull it back, but it will not come back. Different from most of our clothes, when you pull them, you will fit in and then they'll come back and stick to your body. That is being elastic. And what happens is that this elastase that breaks down elastic tissue is actually broken down. Is broken down by what we call the alpha 1 anti the antitrypsin. So what smoking does is that it's going to lead to the reduction of the alpha 1 trypsin. Is going to activate also elastases. Besides that, smoking is going to activate neutrophils because of the chemicals that it contains to go to the area causing inflammation. So that smoking does three things: attracting neutrophils, and then also inactivating alpha 1 antitrypsin, or reducing alpha 1 in antitrypsin. That means that elastase is going to be working, breaking down your elastic tissue. Smoking also just activates the elastase. And what is going to happen is that you have got a destruction of the elastic tissue. This is important. So after the end, now let's just mention this and then we continue to answer our questions. At the end, when there is now this difficulty in breathing, what is going to happen? Because that's one important thing. So, what will be the complication after you have done you've destroyed your airway and there is difficulty in removing air? And one thing we need to know is that for chronic bronchitis, for it, there is going to be more of the, you are going to have more reduction in oxygen, and there's going to be increase in carbon dioxide because we are failing to remove it. So where oxygen is concerned, it's more of the chronic bronchitis, where we are going to have more reduction in oxygen. For emphysema, it is more of a difficulty in the removal of carbon dioxide. Oxygen might be there, a bit of it. Okay, so the complications of COPD, chronic obstructive lung diseases. Number one complication is going to be pneumonia. You know, pneumonia is going to be, remember, there is difficulty in removing things, right? There is difficulty in pushing away things here because there's airway obstruction. That way, airway obstruction is also going to lead to difficulty in clearing the bacteria that might have gone to the alveolar. And so, because there is difficulty in clearing the bacteria, that leads to inflammation there, and that is basically pneumonia. Number two complication is respiratory failure. So what is going to happen with the respiratory failure is, specifically for the upper respiratory tract, let's say there is infection of the upper respiratory tract with viruses, or maybe someone had COPD, but then they are not taking medications, or just the viruses. This is going to be able to lead to respiratory failure. How it is going to increase or propagate the increase? Remember, these are viruses, these are microorganisms. There's going to be inflammation happening because of the virus. And you remember, inflammation is what caused chronic obstructive inflammatory disease or chronic obstructive pulmonary disease. So because of that, it is just worsening the condition, and the airway will end up becoming even much smaller, and that is going to lead to respiratory failure. Because the airway have become even much smaller, it means that there's going to be more work for you to breathe. So there's going to be increased work of breathing, and also there's going to be increased the respiratory rate. Another complication that you are going to be able to see is what is known as pulmonale. In pulmonale, what is happening is that because you have got this lung disease, there is a reduction in oxygen because you are not taking in oxygen to the lungs, and then you are not removing carbon dioxide. But the major thing is oxygen reduction, which happens even more in chronic bronchitis than in emphysema. So this reduction in the oxygen is actually just itself is a potent vasoconstrictor of the pulmonary blood vessels. So the blood vessels that are coming from the lungs, they are going to start constricting because you don't have enough oxygen. And because of that constriction, that is going to increase pulmonary vascular resistance. Like, these guys have become small, so the blood going to the pulmonary arteries has become small. Remember, now these guys are coming from where? They are coming from the heart. And specifically, the pulmonary artery comes from the right side of the heart, isn't it? So there is resistance because these guys have become small. Guess what will happen to the right side of the heart? The right side of the heart is now overworking to push blood to the lungs. And what does that cause? The right side of the heart is going to be able to hypertrophy. And when the right side of the heart hypertrophies, what happens? Later on, after the hypertrophy, is going to also get tired, and so that is going to cause right-sided heart failure. Now, if the right side of the heart is failing, what happens is that, remember, first, this right side of the heart had to hypertrophy. So since it has become big, it means that there is a small space for blood coming from the rest of the body via the vena cava to reach, and so the blood will start going back. When the blood is going back, that is known as a increase in central venous pressure. And what does that cause? If the blood is going back to the jugular vein, that is going to lead to jugular venous distension. Besides that, if the blood is going back to the liver, it causes hepatomegaly. If the blood goes back to the, let's say, to the superior mesenteric vein, inferior mesenteric vein, it will start, the blood, because it has increased in these veins, it will start coming out. And it is going where? It is going into the peritoneum. And that causes what? Ascites. ascites. And besides that, when the blood reaches to the distal veins, that is going to cause the peripheral edema. So those are complications. And besides that, another complication that can result is polycythemia. Polycythemia. Because there is a reduction in oxygen, instruction is going to be sent to the kidney to say we don't have enough oxygen. Maybe because we don't have enough erythropoietin, so the kidneys will start making erythropoietin, and that is going to cause polycythemia. So that is at least something we should know about chronic obstructive lung disease. So number one thing that I've not mentioned here is that on the emphysema, we said that the problem is that we are destroying elastic tissue. The destruction of elastic tissue can be because of either we have got an increase in the alpha. Remember the protein that is supposed to break down elastase. So either we have got a decrease, right? A decrease in what? Alpha 1 antitrypsin. There is a decrease in that guy. Another problem that can be there is if this is not decreased, even smoking. But remember, smoking can even itself cause a decrease in that. But specifically, when someone is smoking, just think of smoking. This is the lung. You know, smoke is light. It will be going up. So smoking more results in the emphysema that affects the upper lobe of the lung, and that is known as centri acini. Centri acina emphysema. And then for the decrease in alpha 1 antitrypsin or the deficiency, it is going to cause a pan acina emphysema. Pan, pan means total, like almost all the acina are destroyed, and more especially those which are at the bottom. So take no smoking, top, and then the alpha 1 bottom. Okay, there. So what type of emphysema is commonly associated with smoking? Back to what the doc had already told us. Anyone that can remember? We've even mentioned it now. Thank you so much. So centri acina. And then be briefly describe how smoking can lead to emphysema development. Anyone that can describe? We've already done that. Anyone? Anyone that can help us describe how smoking is going to lead to emphysema? Doc, basically that. Number one, smoking is going to introduce harmful chemicals to the lungs. Those are going to increase the neutrophils coming to and the macrophages. So there's going to be chemotaxis. They are coming to the lungs, and that leads to inflammation. Inflammation is going to lead to the release, because these inflammatory cells that have come, the neutrophils, are going to start releasing elastases, and those are going to break down elastic fiber in the alveoli. Okay, and you know what happens later. Besides that, smoking also reduces the levels of alpha 1 antitrypsin, which breaks down elastase. So, meaning there's nothing to break down elastase. Elastase is going to increase. Smoking also actually activates the elastases, and they end up breaking down elastic fibers. So, that's that. Thank you so much. And then, question C: based on biochemical data, what acid base imbalance has the patient developed? Okay, the data has been given. Look at this. Look at the pH 7.2. The normal is 7.35 to 7.45. So, based on this, what acid base imbalance is this? Anyone? Thank you so much. So, there is a respiratory acidosis. How do the biochemical results of this patient differ from those in the patient with an acute asthma attack? All right. And then E, describe what would happen if this patient were given oxygen to breathe by face mask. What happens? Anyone? If you much. I hope we've gotten that explanation. A quick summary of what the doc has said. Remember, this person has got what? Look at the partial pressure of carbon dioxide. It's high, isn't it? And forget about the partial pressure of carbon dioxide because we're talking about giving them oxygen via the mask. So the partial pressure of oxygen here is what? Low. So what keeps a person breathing is when the reason as to why we are breathing normally like this is because when carbon dioxide increases, we breathe out. We want to remove the carbon dioxide. But then for this condition, the lungs are blocked. The lungs are blocked. So what is keeping the patient breathing is not the increase in carbon dioxide, but the low oxygen. So actually hypoxia, as you can see. So low oxygen and the lungs are blocked. The low oxygen is the one that is stimulating breathing by going to the respiratory centers. Hypoxia stimulates the respiratory centers. So if you give this patient oxygen, what does that mean? That will tell the respiratory centers to say, okay, oxygen is now normal. So if oxygen becomes normal, it means that they will say, stop breathing because there is no stimulus. Because the carbon dioxide, this is stimulus for breathing out, is not enough. The lungs are blocked, so it's not enough to cause that breathing out. So that is a problem. Providing oxygen is going to suppress the respiratory drive, which is caused by hypoxia, and that is going to lead to reduction in ventilation. If there's a reduction in ventilation, that is going to mean that carbon dioxide is going to be retained even all the more. There's going to be retention because you're no longer breathing. Okay, you're no longer breathing in and out. And so that worsens the condition. F. What complication of emphysema as this patient most likely? This patient is core pulmonale. So we know core pulmonale is there's going to be failure of the heart. So that is it. There's going to be heart failure, isn't it? Core pulmonale is the blood is not going enough of it. There's going to be constriction of the pulmonary vessels that causes pressure from the right side of the heart to increase, and that causes hypertrophy, and that hypertrophy is also going to result into the right side of the heart failing. So the conditions exist altogether, especially if it is a chronic, like the condition as you've been told this has been for long. So likely there's going to be right heart failure because of the chronic pulmonary heart disease. Sorry, the chronic pulmonary disease or chronic lung disease. This one has been for long. The renal failure, renal, the respiratory failure will actually be the one leading to the core pulmonale itself. You are the new doctor in town, and on your first call day, a 55-year-old woman presents to the emergency room. On examination, you notice she has a low Glasgow Coma scale, which is 8 out of 15. Remember, like a 3 up to 80, that is really severe. Like someone, the Glasgow Coma scale is used to test someone's alertness levels. 3 to 8 is really bad. It means that someone is really in severe depression. There is really effect on the central nervous system. And then a thread pulse. She appeared jaundiced. Can see jaundice there, multiple spider nevia, present on her trunk, and she has a massive ascites. Her JVP is raised, so raised the jugular venous pressure. And auscultation reveals the third and fourth heart sounds. Her husband tells you that she has been a heavy drinker. Okay, you know, drinking, what it does to the liver, and poor dietary habits. And she had previously had the liver trouble. Take note. She had begun to vomit blood. So there is hematesis there. Blood was taken from for emergency investigation, which shows the following. On renal function test, you can see sodium 129. Sodium is low. Potassium 4.5. Potassium is basically normal. Urea 7.1. Urea is high. Creatinine is also high. Glucose, you can see, is low. Ammonia is high. The number is supposed to be less than 40. And then on acid base, the pH is 7.5. This guy is high. Remember, the normal pH is 7.35 to 7.45. So this is high. Partial pressure of carbon dioxide 6.5, which is also high. And then you also have the SBC being 35, which is high. Liver function tests, total protein. The total protein is 80, which is normal. Albumin is 20. Albumin is low. You can see normal is 35 to 50. Total bilirubin is 345, which is high. And you saw the jaundice. And then conjugated bilirubin is 290, which is also high. ALT, these are liver enzymes. You have got 60, which is high, and that is a sign that the liver is failing. Alkyl phosphate 45, 445, which is also high, and GGT is high. Basically, liver enzymes are elevated. Give three likely causes of the patient's low GCS, glaucoma scale. Any three causes, why can someone have a low GCS? Meaning that they are not, this is the test for alertness. If someone fusion, that can affect the glaucoma scale. Thank you. That's one. Anything else? Thank you so much. An increase in ammonia. Let me just mention something here. What happens that normally ammonia goes to the liver. Here is our liver. And ammonia is toxic. So we have got a lot of bacteria in our GIT that will be able to produce ammonia. So ammonia will go to the liver to be converted into urea, which is less bad. But since the liver is failing, as you can see from the question, ammonia will end up accumulating, and ammonia is going to go to the brain, and it is going to result in what is called the hepatic. Hepatic is because of the liver, and that is affecting the brain. Hepatic encephalopathy. Right. So that is the another problem. Anything else? Anything else that can cause even the alcohol? Because we've been. Thank you so much. So from the question, let's look at the question. She appears jaundiced and she is a heavy drinker with poor dietary habits. So just heavy drinking itself, if remember from what we did when we are talking about the neuroscience, uh, alcohol and also the withdrawal for alcohol can cause confusion, right? Anything else in case someone wants to say another thing? Even the imbalance, thank you so much. The imbalance in iron, like we saw someone has got hyponatremia. So that is electrolyte imbalance. Okay. So even for you see in this question, they've said the patient was vomiting blood. Vomiting, leads to a decrease in the volume or fluid volume. And when there is decrease in fluid volume, what happens? That is going to lead to shock. And specifically, what type of shock is that? That leads to hypovolemic shock. Okay. And then question B. What acid base disturbance has the patient developed? And what is the most likely cause? So from the data that we have here, you can see that even the partial pressure of carbon dioxide, you can see it is high. So what acid base imbalance is this? Answer here is metabolic alkalosis. If we look at the pH is beyond normal. That means it's alkalosis. So the next thing is to determine whether it's metabolic or respiratory. When you look at bicarbonate, SBC is high. Bicarbonate is related to metabolism, not the respiratory system. Because if it was the respiratory system, what causes respiratory alkalosis is because of hyperventilation. So here it is going to be that. But why is it that partial pressure of carbon dioxide might be is high? So the respiratory system is now trying to compensate. You have got alkalosis. The respiratory system is trying to compensate by increasing carbon dioxide. So it is compensating with the respiratory acidosis. Okay. So we can go to the next question. What is the most likely explanation or explanations for why the total protein level remains normal despite the low levels of albumin? As you can see from the liver function tests, total protein here is 8, which is normal, but albumin is low. Why is it that we have got normal total protein but low albumin? Anyone? Graph that shows the proteins in the body like this. So I've got a nice graph like this. This is showing the first one is albumin, and then albumin, you have got albumin there, and then you are going to have the rest. The rest are globulins. So I've got alpha 1 globulin, alpha 2 globulin, and then you have got beta globulin and gamma. So beta and gamma, one of these, beta is the antibodies, and then gamma, these are clotting factors. So these are globulin. So you can see there is a decrease in albumin, but it's not the only protein. Look at the other proteins, the globulin. Albumin is not the only protein, serum protein. So when there's a decrease in albumin, there's going to be an increase in other proteins in the body, like the gamma globulins, the beta globulins, the alpha 1, the alpha 2. Those are going to be balancing that decrease that is in albumin. They are going to be increasing. And so that makes the total being just normal. Okay. Actually, the globulins are going to be produced as compensation because the liver is failing. The globulins are produced as compensation to the decrease in the albumin. And then question D, what life-threatening complication may arise in this patient because of her ascites? Anyone that can help with that one? Okay, question C, there's going to be an increase in globulins. There is a decrease in albumin. That decrease in albumin can reduce the total proteins. But as a compensation, the body is going to be producing the globulins. And that is also going to help in maintaining the total globulin level, the total protein level, sorry. Right. And then for D, what life-threatening complication may arise in this patient because of our ascites? Stimulation in the peritoneal cavity, and this is going to be seen. Someone has got a distended abdomen. Actually, there is going to be positive shifting downwards and fluid thrills. Now, this can be caused by two things. You can have transudate fluid, transudate ascites, or exudate. I know we know the meaning of these two terms. So in transudate, let's say here is our liver, and in the liver you have got the splenic vein and the superior mesenteric vein. These guys come and they join to form the hepatic portal vein or the portal vein. And then you know that blood coming from the liver can as well flow out via the hepatic vein. So this is hepatic vein, and then this is the portal vein. Portal vein. So what is happening is that for this, if we just enlarge the portal vein, there can be an increase in pressure in the portal vein. And when pressure increases, what happens that fluid is moving out of the portal vein, going into the peritoneum, and that leads to ascites because there's an increase in fluid in the peritoneum. But specifically, this fluid that is going is a transudate. It's only the water coming from the blood vessel. But then what can lead to that? It can either be a blockade after the liver, in the liver, or just in the portal vein itself. So those are the causes of transudate ascites. So I've got a post sinusoid. Remember, in the liver, I've got sinusoids, right? Those are small blood vessels in the liver, sinusoid. So I've got post sinusoidal, sinusoidal, and pre-sinusoidal, or hepatic, pre-hepatic, post-hepatic. So before in the portal vein itself, before the liver, that is pre-sinusoidal or pre-hepatic. The major cause that you can maybe have an emboli in the portal vein. So that is portal vein thrombosis, not an emboli, but a thrombus. Because an embolus, that one moves. So that can be blocking the blood going to the liver, and that will make the pressure this side before the thrombus to accumulate, and that leads to fluid moving in the liver. One cause can be the liver has got cirrhosis. There is liver cirrhosis, and actually that's the biggest cause, and that liver cirrhosis is blocking these blood vessels, so blood is coming back, and that can lead to the movement of fluid after the liver. That is post sinusoidal. Someone can have right heart failure. When someone has got right heart failure, fluid comes back to the rest of the body, and it will be coming back into the hepatic vein, because the hepatic vein drains in the inferior vena cava, and that will still cause that is going to cause ascites. Besides that, there's also what is known as bad carry syndrome. So in this syndrome, there's also going to be a clot in the hepatic vein, and that clot in the hepatic vein is going to cause fluid to be going back into accumulating in the hepatic vein, and that increases the pressure, and then fluid starts to move out. In exudate, so there is something that they calculate here. There's what they call the serum ascitic albumin gradient. Serum ascitic albumin gradient. So for transudate, what happens here is because the albumin that is present in this guy is actually calculated by saying serum albumin minus acetic albumin, like the albumin that is present in the peritoneum. So in this condition specifically, the albumin is not leaving the blood vessel, so the albumin is normal. Okay, but because we are diluting the peritoneum, the albumin there is going to be decreased. And you know that if you subtract a constant number from a decreased number, the number is going to appear big, isn't it? Let's say, for example, the number was 10 minus 5, but this is still 10, but the albumin in the peritoneum has decreased, let's say, to 4. So this number is going to increase. So this number is greater than 1.1. That shows you that there is transudate. In exudate, what is happening is that there's actually a break in the blood vessels themselves. And so fluid is moving out of the blood vessels going into the peritoneum together with albumin. So there's actually a decrease in albumin, serum albumin. So since there's a decrease in serum albumin, and then that serum albumin is going into the peritoneum. So there's a decrease in serum albumin, but there's an increase in the albumin that is going into the peritoneum. So there's going to be this number, the serum ascitic albumin graph is going to drop less than 1.1. That shows that it's exudate. So that is ascites. And because you are taking fluid, remember these blood vessels specifically, we said that they are being formed from, you are having the superior mesenteric and you are also having the splenic vein. So these are guys, these are arteries of the GIT. So what is going to happen is that when blood is going back, is going into the peritoneum, the problem there is that it can actually get to, also the bacteria can move. The bacteria in the GIT can go into the lymph nodes of the GIT. And after going to the lymph nodes, the mesenteric lymph nodes, the bacteria can now go into the abdomen. And that causes spontaneous. There is no infection. There is no infection. That's why it is called spontaneous bacterial peritonitis. Because peritonitis can as well happen because of some underlying infection, but this one is just happening like that. That is a worst complication of ascites. It is very bad, it's deadly. Imagine a bacteria accumulating in the peritoneum. What underlying cardiac pathology might have developed in this patient? Anyone to help us with that? What underlying pathology might have developed, cardiac pathology might have developed in this patient? Anyone? Okay. So let's mention here. This is our heart, and you know you have got the right side of the heart and you have got the left side of the heart there. There is our heart, simple. And then you are going to have from your ventricles, you are having the aorta going to the rest of the body. Then you are also having the vena cava coming here, and then it will be leaving, going to the pulmonary. So when you are talking about conditions which we call cardiomyopathy, this is just a problem of the heart, cardiomyopathy. We have got three main types, and these ones is high yield. We really need to know them. So, number one type of cardiomyopathy is known as dilated cardiomyopathy. Number two is known as hypertrophic cardiomyopathy. And then number three is known as restrictive cardiomyopathy. So, what happens in dilated cardiomyopathy is that the heart, specifically this side, okay, more because the left side of the heart is what pumps blood to the rest of the body. The left side of the heart is failing to contract. There's reduced contractility because of some problem, underlying problem. And the problems that can cause that reduced contractility, number one, can be alcohol. Number two, it can even be beriberi, where you have got deficiency of thiamine, beriberi. Okay, and some other conditions like Chagas disease caused by triple T. cruzi, Chagas disease. So these guys are going to cause reduction in cardiac, in contractility of the heart. That reduction in contractility, guess what happens? There's going to be reduction in cardiac output. If there is a reduction in cardiac output, what happens? There's going to be a reduction in blood pressure. And if there is a reduction in blood pressure, what is going to happen? There is going to, what the body is going to be trying to do is now it is going to be trying to bring a lot of things, blood to the heart, back to the heart. So there's going to be an increase in preload. Okay, that increase in preload is going to cause the heart to dilate. Actually, even the decrease in cardiac output, some of the blood is reducing because it's coming back because there's a reduction in blood pressure. And that is going to cause the ventricles to dilate, and that is known as dilated cardiomyopathy. And so what does that cause? Guess what happens? Because the right side, the heart is now dilating, later on there's going to be heart failure. Okay, the heart will start failing because it's dilating. It will just start failing to pump blood. And so because it has failed, it will start also failing to pump a lot of blood. There's going to be a reduction in ejection fraction. And specifically in dilated cardiomyopathy, you are going to see what is known as eccentric hypertrophy. Okay, eccentric hypertrophy. Please, this is important. Like the heart, you are going. If you look at the and this one is mentioned to say, I can just bring a diagram. Like when you look at the heart, you're going to see like hypertrophy around like so. So that's the problem. And then when you come to the hypertrophic cardiomyopathy, this one is specifically affecting the septum of the heart. So what you are going to see is that there's going to be septal hypertrophy. Please take note, that is high yield. Septal hypertrophy. And the septal hypertrophy, what happens? Look at this. If the septum has dilated, it is actually going to lead to the ventricles to become small. So let me write this because it's high yield. Are you even clearly getting me because of these rains? Someone confirm. All right. I'll try to maintain my voice. Okay. Yes, please. Okay. So we are saying that in hypertrophic, specifically, it is only the septum of the heart that has become big. And what this causes is that there's going to be difficulty in pushing blood from the heart, and more especially from the left side of the heart. So there's going to be a left ventricular outflow tract obstruction. Please, this is important. Like the left ventricle, you know you are going into the aorta, right? So because the left side of the heart has hypertrophied, it's actually making it difficult for you to push blood from the left ventricle. That is left ventricular outflow obstruction. Please take note of that. And the problem in septal hypertrophy is actually known as concentric hypertrophy. And so that is going to lead to a reduction in the filling of the ventricle. Because remember, the ventricles have become small because of the beginning or the widening of the septum. So there is going to be difficulty in filling of the ventricles. And that later on is going to cause heart failure. And the bigger cause for hypertrophic cardiomyopathy is actually a problem that is genetic. Like the heavy chain, remember this guy is made up of muscles. So the heavy chain of the myosin is gone. There is a gene mutation. So there's heavy chain myosin gene mutation. That is what causes this. For restrictive, the problem has nothing to do with dilatation. It has nothing to do with hypertrophy. The problem with the restrictive is actually there is just a myocardial infiltration. Like these are the ventricles. There is some infiltration. Something has gone into these myocytes. And what can infiltrating diseases can include amyloidosis. So amyloid proteins have ended up infiltrating into the myocytes, the cardiac cells. You can also have sarcoidosis. Okay, those are some of the problems. And so what is going to be happening here is there is no hypertrophy, there is just infiltration, which is going to make it hard for the ventricles to expand. Remember, if there's infiltration, The ventricles can't expand to accommodate blood. And so, because they can't accommodate the blood, it will also be hard for them to push the blood out. Please take note of that. That's high yield. And one complication that you're going to be able to see will be the heart failures that you've just described, the right sided heart failure, the left sided heart failure. But more specific for the hypertrophic cardiomyopathy, you are going to see someone is going to, they are going to describe a scenario, maybe like someone is playing football, they just end up fainting, they die just like that. That is because for hypertrophic heart failure, there's going to be a reduction in perfusion. Remember, we have said that you are failing to pump blood to the rest of the body. So specific features that you're going to see in hypertrophic heart failure is there is a reduction in systemic perfusion. So because blood is not going to the rest of the body, if blood doesn't go to the brain, there's going to be fainting. If the blood is not going to the heart itself, there's going to be ischemic disease of the heart, and that causes angina, pain of the heart, because the heart itself is not receiving blood. There can also be ventricular tachycardia and ventricular fibrillations. These are the ones that actually leads to sudden cardiac arrest, and then a young man that is playing football just ends up falling down and then they die. They are gone. And another problem that you can be able to see besides the perfusion is the pulmonary edema. Remember, we said this is affecting more specifically if it is this side of the heart, the right side of the heart is failing. So blood is going to the rest of the body, right? But if the left side of the heart is failing, blood is going back to the lungs. And if it goes back to the lungs, it is going to increase there, and that is going to cause difficulty in breathing, dyspnea. And another feature that you are going to see will be a murmur. So if you see these features, a murmur, edema that is going to cause pulmonary edema that cause dyspnea, and also reduction in perfusion like fainting, ischemic heart disease, that those are complications of hypertrophic disease. For restrictive disease, most you are going to hear of what is they call Kussmaul signs. This is where someone is just having difficulty in breathing, and there's also raised the JVP. Okay, so what underlying cardiac pathology might have developed in this patient? Look at the causes for dilated cardiomyopathy, alcohol. And we've been told in this scenario that the patient is actually a very heavy alcohol person. So we expect that this patient is going to have alcoholic cardiomyopathy, which is specifically what? Dilated cardiomyopathy. Okay, and that maybe resulted in heart failure. So, what X-ray findings would support your answer? Because there is dilated cardiomyopathy, the heart has become big. So, you are going to do what? You are going to see cardiomegaly when you look at the heart. So, basically, that. Are we fine with this question? Are we okay? So, question F, there's going to be cardiomegaly. Question E, there is dilated cardiomyopathy, which is actually alcoholic cardiomyopathy. And that you can see it on the x-ray by seeing a big heart, right? Question 6, a 40-year-old woman presents to the hospital with swelling in the anterior part of the neck around the Adam's apple. When she's asked to swallow saliva, the mass also moves. Her doctor tells her that she has a goiter. The doctor further states that this patient's nodule is a cold nodule and in surgery will be necessary. A pathologist makes a diagnosis of papillary thyroid carcinoma. What is as simple as that? A goiter is just the abnormal enlargement of the thyroid gland. Okay, just that. If you have got iodine deficiency, it can cause a goiter. Even hyperthyroidism, even euthyroidism, even when the thyroid is normal, anything can cause the condition. What is a cold nodule? Anyone? What is a cold nodule? Okay, so let's say some. This is the thyroid gland. It has got a problem. And then the rest, you have got the rest of the tissue this side, the rest of the cells. So one diagnosis when you are trying to see about the problems with the thyroid is you are going to use iodine, okay, radioactive iodine. And when you pass radioactive iodine in the body, only the thyroid gland is supposed to take up, or the thyroid cells are supposed to take up iodine, specifically radioactive iodine in this case, because we're trying to make a diagnosis. So a cold nodule is one that fails to take up the radioactive iodine when you are performing the test. Is actually called scintigraphy. So a cold nodule is a nodule that does not take up the radioactive iodine. So if you see now iodine, let's say for example, you find that in the bone is taking up iodine, you are going to be thinking maybe there is metastasis of this thyroid cancer to the bone. Or if you see like the some other tissue are taking up the radioactive iodine, you will know that maybe this cancer has metastasized to that tissue because it's only the thyroid cells that are supposed to take up the iodine. All right. What special test would you conduct to diagnose medullary thyroid carcinoma and state what you expect? Now, when you're talking about thyroid carcinomas, just like any other carcinomas, normally they are going to start just like dilatation, hypertrophy, which can just be dysplasia. The cells are just abnormally dividing. So when you come to so a thyroid, a cold nodule is a nodule that does not take up radioactive iodine. Yes. So when you're talking about these adenomas or these can not adenoma, remember when you're talking about cancers, they will start first as benign, right? They are adenomas, thyroid adenomas, and then they're going to come to become cancerous. So you are going to have papillary thyroid carcinoma. You are also going to have follicular thyroid carcinoma. You're also going to have what is known as the aplastic thyroid carcinoma. These three specifically, these guys are going to affect the actual follicular cells. Remember, for the thyroid gland, you have got follicular cells, and then now you have got C cells. Okay, C cells which produce calcitonin. So we also have medullary carcinoma. Now, a medullary carcinoma affects the C cells. These others will affect the follicular cells. So when you talk about a papillary carcinoma, this guy mostly affects young people, like young women. So in histology, you are going to find a solid irregular mass or even a cystic mass or nodule that is present in the normal parenchyma of the thyroid gland. For example, you just see a mass there, okay? And then you are, some things that you are going to see is the when you look at the histology of the cells, there's going to be empty appearance of the nuclei with the central area being clear. Okay, the nucleus is looking empty and it has got a specific term. And you are also going to see what they call samoma bodies, which are basically a collection of some form of just some masses there, some samoma bodies. And then you're also going to see like the lateral group of jugular lymph nodes being affected. That's a papillary thyroid carcinoma. Follicular one, mostly you are going to see miss minor follicular follicles, a lot of them, and they're going to have a lot of nuclei. You know the follicles are supposed to be big like that, but then you see a lot of small follicles, a lot of them. So you are thinking of follicular carcinoma, okay? And these guys show invasiveness into blood. And then for the aplastic, these you are going to see a carcinoma. The cells have divided, but then they've got different shapes and different sizes. Like you are going to see some are giant cells, others are spindle cells. Now for the medullary carcinoma, this guy is affecting the C cells. So there's actually hyperplasia of the C cells, and it's associated with some conditions. So we're going to see what they call main 2A and main 2B. Okay, so these are some genetic conditions that you are going to be able to see. So this is endocrine. This E in the main is representing endocrine. So these are, you are having genetic problems, and then it's affecting a lot of endocrine cells instead of only one, a lot of endocrine organs. Like specifically for the main 2A, you are going to see there is a thyroid medullary carcinoma. There's also going to be a carcinoma of the adrenal gland, what's known as pheochromatoma. Like there's going to be production of the adrenaline and those guys. And then another thing that you are going to see besides the pheochromatoma and the thyroid medullary carcinoma is parathyroid gland also being involved. But in men 2B, there is also thyroid medullary carcinoma and pheochromocytoma, but there is no involvement of the parathyroid gland. Instead, you are going to see multiple neuroma. There is involvement of the nerves. Please take note of the difference between men 2 and men 2B. So that is everything there, and so we can now answer our questions. What special test would you conduct to diagnose medullary thyroid carcinoma? Just think of it, it is affecting a lot of other endocrine glands, as we've said. Anyone that can help us with that? Anyone? Okay. Remember what we have said about this condition? It is affecting a lot of endocrine glands. So some things that you can do is you can look at the levels of calcitonin, because it's the condition itself is affecting the C cells which produce calcitonin. Calcitonin responds to high calcium so that it balances it. It's actually against parathyroid hormone which responds to low calcium. So you can look at calcitonin. Also state what you'd see. You are going to see high levels of calcitonin because this problem is affecting the C cells, making them to overproduce their hormones. And then you are also going to perform some genetic testing. On genetic testing, specifically, you are going to see what is known as rate pronto oncogen. Rate pronto oncogen, and this is the one that is going to be, which you can divide into the main 2 and the main 2B. So the red pronto oncogene is associated with the familial cases of the medullary thyroid carcinoma. Familial means that it flows in the family. So the red proto oncogene. It is a cancer. It's a cancer gene. Okay. So it can either be main 2A or main 2B. And then you can also do some imaging studies. So for the genetic testing, you are going to see it's going to be positive if it is familial. And then you can also do a fine needle aspiration so that you get some cells, you take them to the microscope. And what you are going to see is that for those cells, you are going to see some amyloid deposits or some spindle shaped cells. If you see those, then you confirm. And then you can as well do some imaging studies like the CT scan or MRI. You just want to see the extent of the tumor. Okay, so those are some things that you can do. And then D, contrast Hashimoto's thyroiditis from Graves' disease. Anyone that can help us? Thank you so much, Doc. So that's that. You know that just like the doc has said, from the hypothalamus we release a thyroid releasing hormone. It stimulates the anterior pituitary to release thyroid stimulating hormone. That goes to the hypothalamus to the thyroid gland to cause the release of the thyroid hormone T3 and T4. So in Hashimoto's disease, this is autoimmune, and this autoimmune disease is actually destroying the thyroid gland. If you destroy the thyroid gland, you'll not be able to produce the thyroid hormone. So there is hypothyroidism. That is one important thing. Hypothyroidism. Now, for Graves' disease is also an autoimmune disorder. Okay, autoimmune. But what is happening is that in this Graves' disease, there is production of thyroid uh, stimulating immunoglobulins. These thyroid stimulating immunoglobulins, what they do is that they behave like thyroid stimulating hormone. So what they will do is that they are going to be working on the thyroid gland. These are antibodies, they are immunoglobulins. They are now working on the, instead of destroying the thyroid gland, they are stimulating the thyroid gland to produce more of the hormone, and that is what is leading to hyperplasia of the cells of the thyroid gland, and that causes hyperthyroidism. Now you know that the thyroid gland is involved in utilizing energy. So in Graves' disease, you are going to see someone becomes fat because there is utility of the carbohydrate. Someone is going to becoming thin. Sorry, there's utility. You are using the energy from the body. You are breaking down the lipids. But Hashimoto disease, someone is going to become fat, heat intolerant. Why? Because you are not using up the thyroid hormones, and those are hormones that help you to break down, like to use your carbohydrate to break down your fat. Why does goiter develop in a patient with iodine deficiency? Anyone that can help us with that? Why does goiter develop if someone has deficiency? Yes, doc. Thank you so much. Just what the doctor said. Reduction in iodine because of the deficiency of the iodine is going to be stimulating. There's going to be a feedback mechanism, all right? Negative feedback mechanism. So that is going to stimulate the anterior pituitary gland to start releasing thyroid stimulating hormone, because it's saying we don't have enough thyroid, because iodine is necessary in making thyroid hormone. So that iodine being low means that you can't make the thyroid hormone. That reduction in thyroid hormone stimulates the thyroid stimulating hormone to be produced from the anterior pituitary. That is now going to be coming to stimulate the thyroid gland to make more hormone. But you don't have iodine, so there's going to be hyperplasia of the thyroid gland. And that hyperplasia is now going to lead to the goiter. List two important histological features of papillary thyroid carcinoma. Anyone? Thank you so much. So, what the doctor said, please remember this. There is what is known as the orphan of how someone was. So, orphan and eye nucleus, this is the appearance of you have got a nucleus that is clear and empty. Okay, so that is one thing that you are going to be able to see. Actually, it's a cell. The cell, as we said earlier, you have got this cell which is clear and there is empty appearance. And then you also going to see what they call samoma bodies. So these samoma bodies, these are concentrically laminated, like these are calcified structures that contains calcium. Besides that, you're also seeing from the word papilla, just that means finger-like. So you are seeing finger-like projections. Okay, finger-like projections. That's how the name comes about. Okay, so these are some histological features that you can see in this condition. Number 7, James was a young 40-year-old and energetic athlete who played soccer for one of the big football clubs in Europe. He suddenly collapsed and died while on the soccer pitch 2 days before. An autopsy was conducted. The only significant finding was that there was an enlarged heart. The left ventricular free wall was normal, but the interventricular septum was enlarged. There were no muscular or valvular defects. Note that before his death, James was reported to have been very healthy. He did not have a history of suffering from hypertension. What is your diagnosis in light of the history and the postmortem findings? Provide a complete diagnosis. Anyone to help? So much. So the problem here, if you just hear interventricular septum, remember it's not affecting the ventricular walls, and the heart is enlarged. This is hypertrophic cardiomyopathy. To be specific, asymmetric septohypertrophy. Asymmetric septohypertrophy, which is hypertrophic cardiomyopathy. Okay, you know the septum has become big. What are the histological findings of this condition? Anyone know that? You know how cells are supposed to be arranged. They're supposed to be properly like that, well arranged, going in one direction. But then in hypertrophic cardiomyopathy, they are disarranged, or whatever English that you can use here. There is no proper arrangement. So you call that as a disarray of the cardiac myocytes. So the myocytes are not organized, they are disorganized. That is one histological finding that you're going to see. They can bring that diagram. If you just see that, you'll be able to tell. Besides that, because you are you are not actually, there's also failure because the tissues, the heart itself will be not getting enough blood. There's actually going to be fibrosis. Okay, there's going to be fibrosis. There's death of the cells, and then there's this fibrosis within the myocardium. And besides that, remember this is let's say this is your heart. It's very it has big it has the septum has hypertrophied, and this is the blood vessel that is supplying the heart. You can see where it is ending. This is the inside of the heart. That's the endocardium. So because the septum has become big, what does that mean? That means that you are not going to be able to reach to the full thickness of the structure of the septum. So some part will end up dying like that. And another thing because of that you are going to be able to see is the thickened septovessels. These blood vessels that supply the septum will be thickened. So thickened septal vessels. Apart from that, you can as well see the actual myocardial hypertrophy. Okay, the septum, the cells have hypertrophied on the septum. They increased in size. What are the histological findings? So that's that. We've mentioned at least three. We actually mentioned for this array, fibrosis, thickened septal blood vessels, and also the actual hypertrophy of the cells. Which part of the heart would be affected if he was older and had a long history of hypertension? Anyone to help? Thank you so much. So it is the wall of the left ventricle, and we are thinking of the this person has got hypertension, and you know it takes a much longer distance to go to the rest of the body because that's what the left ventricle does. The right ventricle pumps blood only to the lungs, which is near. So expect that if someone has got hypertension, high blood pressure, it's affecting more of the left ventricle because you are finding it hard to pump blood to the rest of the body like that. Okay. So the wall of the left ventricle is being affected. Left ventricular free wall. Describe the pathogenesis of hypertensive heart disease. So how does hypertension lead to heart disease? Is in high blood pressure, isn't it? So the increase in BP, specifically because this has, especially if it's chronic, like chronic BP, okay, chronic increase in blood pressure is going to increase the workload of the heart. It's making it hard for the heart to pump blood. So there's going to be increase in workload of the heart. It's doing a lot of work. And this is chronic because this blood pressure has been there for long. And that increase in workload of the heart is going to cause the left ventricle of the heart, left ventricular hypertrophy, is going to hypertrophy. And the reason as to why it is hypertrophying is because you are adapting to the high blood pressure, because you are pushing against a high blood pressure. The vessel in which you are going has got high pressure. So as you are pushing against that. So you hypertrophy as a way of adaptation. And that hypertrophy, what it does is that it causes the thickening of the muscles of the heart. Okay. And so when you thicken the muscles of the heart, they are going to end up becoming stiff. And when they become stiff because of that thickening, it will impair the ability of the muscles to be able to relax. Think of it, the wall of the heart has become very thick. So it will make it very hard for this thick wall of the heart to be able to relax in order to fill with the blood that is coming back to the heart. So the stiffness of this heart is actually making it hard for it to be able to feel during diastole, which is relaxation, because it can't relax. And over time, because there is a reduction in the ability of the heart to be able to feel, there's also going to be a problem in pumping because you are only receiving lead to, so even pumping out is only lead to. And so that is going to lead to systolic dysfunction. Okay. The pumping of the heart, because the heart is are now becoming that thick, is now stiff, it's receiving little, so it will be now failing to be able to pump out. There's dysfunction when it comes to contraction, also because there's a problem in relaxation. So systolic dysfunction will be the end result. So that is that. Elizabeth is a beautiful young lady from Chawama East. She presented to the clinic with complaints of vaginal discharge for 5 days. You conduct a vaginal swab to rule out an infection. What are the two possible causes of her infection? Anyone to help? She has got a vaginal discharge for 5 days. What are the two possible causes of her infection? Basically transmitted by sex. So you can have things like chlamydia, trichomatis, and also Neisseria gonorrhea, which causes syphilis. So those can cause the problem here. So those are STDs. Can also as well have what is known as bacterial vaginosis. So caused by bacteria, which will lead to this vaginal discharge. Okay. Her doctor decides to screen her for cervical cancer. What is the cause of cervical cancer? Anyone? Thank you so much. HPV. Specifically, the one which is more is the high risk HPV. Anyone that can help us mention some high risk HPVs? 16, 18, these are the most common. Anything else? Yes, so these guys, especially 16 and 18. What is the pathogenesis of cervical cancer in light of your response in part B? So in light, since we've said it's caused by HPV, what is the pathogenesis? There is sexual activity, especially early sex, because the squamous-columnar junction is in the ectocervix. Early sex, there is exposure to HPV. Since the person is exposed to HPV, what happens that the guy HPV is going to use its proteins L1 and L2 to be able to adhere to the epithelium of the cervix. When it adheres, it will now use its protein E1 and E2 to start replicating. When it replicates, it will now use its proteins E6 and E7. E6 is inhibiting the the tumor suppressor gene P53, E7 is inhibiting the tumor suppressor gene RB. These guys stop the unnecessary proliferation of cells. Since you have inhibited them, there is now unnecessary division of cells. So there's dysplasia, cells are dividing and dividing and dividing. And that is going to cause the because of the dysplasia itself, the cervical dysplasia, because the cells are dividing unnecessarily. That dysplasia later on is going to lead to invasive cervical carcinoma. Okay. What are the possible risk factors for cervical cancer that this young lady may have? Please be sure to be able to differentiate the cervical cancer that is affecting the part of the ectocervix and the endocervix. We did talk about that. We have the one affecting the squamous cells, that is ectocervix, will be the invasive squamous cell carcinoma, and then the ones affecting the endocervix, that is going to be invasive adenocarcinoma. What are the possible risk factors for cervical cancer that this young lady may have? Anyone? Thank you so much. Multiple sexual partners. You also call these guys as being promiscuous, right? They are unfaithful. Multiple sexual partners. Even when if same with the Mount Para guys, those who have given birth to a lot of children. This thing is different. For cervical cancer, for those who have got a lot of children, they have got a higher chance of having cervical cancer. But Mount parity is actually going to reduce the risk of breast cancer. So you can see it's opposite. Other things will include being less than like early sex, someone below 16 years, right? Even poor socioeconomic status. If someone is poor, they'll end up going to maybe act as sexual workers, and so they are going to be exposed to HPV. Smoking, very, very important. And also poor utilization of screening. Some people, they don't want to go for screening. And also history of having other STDs. May you say, so for example, someone has got HIV, they have got gonorrhea. Not gonorrhea is not a disease, isn't it? Syphilis, so other STDs. Okay, so such things. Number 9, a 21-year-old lady presented at UTH Women and Newborn Hospital complaining of an absence of monthly menstrual period. Besides that, this beautiful woman has got a headache and loss of peripheral vision. During your examination, you notice that she has a nipple discharge bilaterally. Nice things there. What is the most likely diagnosis? Anyone? Most likely diagnosis? Thank you so much. So this patient has got pituitary adenoma. So this guy, the pituitary gland has become big, right? And so if it has become big, it will be producing a lot of hormones. I've seen, in case you are wondering, other doctors are saying pituitary what? Pro prolactinoma. That is basically a pituitary adenoma that is secreting prolactin. Prolactinoma. It is a pituitary adenoma that is secreting prolactin. Okay. What does the patient have? Why does the patient have the tested visual disturbance? 10 marks. For this question, I'm going to advise, in case it comes and you're answering, please use a diagram, because writing words you are going to they're short. There's too much short words you can use. A diagram is going to explain everything. Okay, you have got, here is your visual fields. Right visual field, left visual field, and then you have got the eye there, where you have got the hemiratin. Okay, so there we know from our data that data from the nasal left hemiratin is going like that, and then it goes like that. And then the data from this side is going like that, is going like that, and then going to the contralateral side, bifurcate. Is that bifurcating or decasseting? And then the other side going like that, and then also the other side going like that. So because we have affected this region, so we can see we have affected this visual field and we have affected this visual field. So we can simply do that and then say a few words. A pituitary adenoma, because the pituitary gland is big, it is compressing the optic chiasm. And compression of the optic chiasm is going to disturb the visual the peripheral visual fields, that is the temporal visual field of the right visual field and the temporal visual field of the left visual field. And so that is why there's peripheral vision disturbance. Explain the absence of the menstrual period in this lady. Anyone that can help us with that one? Anyone? Right, thank you so much. So we know that the hypothalamus releases what is known as gonadotropin releasing hormone. Remember, releasing hormones come from the hypothalamus. That is going to stimulate the pituitary gland to release luteinizing hormone and also follicle stimulating hormone. The anterior pituitary gland releases luteinizing hormone, follicle stimulating hormone. It also releases prolactin. It also releases the growth hormone. It also releases adrenocorticotropic hormone. How many are these? These are five. There's one that has remained. Okay, let's pick it from here. So what happens is that when the pituitary gland, the anterior pituitary gland, releases a lot of prolactin, prolactin acts as an inhibitor of the hypothalamus from releasing gonadotropin releasing hormone. If you don't have gonadotropin releasing hormone, you are going to have a reduction in luteinizing hormone and follicle stimulating hormone. And these guys actually causes the production of estrogen from the ovaries. And estrogen is necessary for those monthly menses and such things. Actually, luteinizing hormone is involved in ovulation, like the actual release of the egg on the 14th day. Since you are not producing those guys, there's going to be an ovulation, and so that is the lack of the menstruation. What diagnostic tests would you order? All right. So, number one, prolactin. Remember, this is a prolactinoma or the pituitary adenoma releasing prolactin. We have got a lot of prolactin being released. Prolactin is an inhibitor on the hypothalamus from releasing gonadotropin releasing hormone. So since we don't have gonadotropin releasing hormone that causes the release of luteinizing hormone and follicle stimulating hormone, there's not going to be any production of luteinizing hormone and no production of follicle stimulating hormone. And the luteinizing hormone specifically, so follicle stimulating hormone is going to cause the follicles to start moving from primordial follicle, primary follicle, secondary follicle, which goes into the Graafian follicle that is mature. And when it is mature, because of follicle stimulating hormone, luteinizing hormone is going to come now to cause the release of the follicle, of the ovary, not of the egg actually, from the follicle. So here is a bigger part. This is the ovary. And inside the ovary, we have got these follicles at different stages. And the follicle that is mature has got the egg inside the ovum. What caused the maturation was follicle stimulating hormone. And then luteinizing hormone is going to cause the release of this egg. So since these two guys have been inhibited, it means that all these top steps have been prevented. So there's going to be no release of the egg. And that is what is causing lack of the menstrual periods. Right. And actually also from the ovary itself, the ovary produces estrogen that is involved in also these menstrual periods. So it is also going to be, it will stop because there's no luteinizing hormone to stimulate the ovary. Okay. What diagnostic test would you order? So the diagnosis is basically we are looking at these guys. We are looking at the hormones. One hormone that I forgot that I was trying to remember that is coming from the anterior pituitary. So anterior pituitary produces six hormones: follicle stimulating hormone, prolactin, growth hormone, adrenocorticotropic hormone. You also have thyroid stimulating hormone. So you are basically looking at these guys. So first thing you can do an MRI or even a CT scan. You are basically looking at the brain to see the tumor. Besides that, you can go in blood, you look at prolactin. So serum prolactin, if you find that it's high, you confirm. Besides that, you can also do thyroid function tests. You are basically looking at if you have got an overproduction. Remember, you are having TSH here. TSH is going to cause the production of what? Of T4. Okay. So we are going to go to the thyroid gland and you want to look at, you are performing thyroid function test by looking at the levels of TSH and the levels of free T4 in blood. So if TSH is high, you expect that the pituitary gland is a problem. But if you have got high T4 but TSH is normal, you expect that actually the problem is from the thyroid gland itself because TSH, which is a stimulator, is normal. So you want to perform these thyroid function tests. And this patient has got also problems with the eye. So you can as well look at some visual field examination. Those you are moving your finger, look this side, so that you just see the compression here. Okay. You want to determine if the peripheral visual loss is really due to the compression on this guy, the optic chiasm, or it can be because of other problems. Those things. You can as well look at ACTH. This guy is going to stimulate the production of the adrenal gland hormones. So you also look at those hormones. Even the growth hormone, you can as well look at it. So all those. Number 10 and last question for this paper, and we are done. A 70-year-old man presents at UTH with a tremor in the hand, rigidity, and a shuffling gait. You also notice reduced facial expression, masked face, slowness of movement, bradykinesia. A relative confirms the elements of amnesia and dementia. Amnesia, forgetting, right? That's same with the dementia, but with some differences. What is the most likely diagnosis? Anyone? What is the most likely diagnosis? Thank you so much. Parkinsonism or Parkinson's disease. If we just say Parkinson disease, it's a disease, but Parkinsonism can be because these symptoms can be caused by a lot. Even alcohol can cause these symptoms. That's why we are saying Parkinsonism. But if we say Parkinson's disease, that's not wrong. Which part of the brain is affected? Anyone? Thank you so much. So basically, the substantia nigra pars compacta of the of the basal ganglia. What change is seen in this part of the brain and why? So what change are we going to be able to see in this part of the brain that you mentioned in the basal ganglia? Th- Thank you. So there's going to be paleness. What is the reason of being pale? Thank you so much. Remember the past compact of the substantia nigra. This guy basically has these dopaminergic neurons. These neurons actually have got melanin, which gives the color, the black color, to the to the structure. So if there's loss of the neurons, it means that even the melanin, we are calling it neuromelanin, coming from the neurons, will not be produced, and so the area will appear pale. What inclusions do we see in the cells of this part of the brain histologically in this disease? Anyone? The Lewy bodies. What protein is in these inclusions? Anyone? What proteins? All right. So the biggest protein that we have is the alpha synuclein. Of course, you can as well see the tau. But please, the biggest you should mention, please mention the alpha synuclein. And that's the end of this paper. Thank you so much. We are done with this paper.